think it's about time we start.
Yeah, sure.
Okay. There's a number of people I want to admit here, and I'm having a technical issue.
What is happening?
Not exactly sure.
Is it not the internet?
Let me try and use a second device. Maybe I will succeed. Okay. I think we can go now, right?
Yeah.
Okay, Seba.
Yes, good evening,
Go on,
everyone.
Sebastian.
Good evening, Seba.
Evening. So yeah, you'll present. I think I'll just be moving the slides. So you just tell me next slide, and then I'll be moving.
So, welcome to our Sunday Afro DX Clinical Known. I'm going to present a case to Dr. Joseph. Dr. Joseph, I hope you're ready.
Yes, I'm ready, Seba.
So, today I'm going to present to you a 46 years old female. Yes, so this is the patient who presented with Dr. David. Can you move the slides? So this is the real patient who presented with history of yellowish discoloration of the eyes for 2 months.
Okay. Thank you very much, Seba. I think you can hear me well. And
Yes, I can hear you.
yeah, first of all, I should applaud you for the what you're doing here. I know you're very busy as a resident, but you can make time and prepare this and present for us to learn and for you also to learn. So, yellowish discoloration of eyes will be translated as jaundice. So, I believe we are talking about jaundice today. And for me, the way I approach jaundice is I think, why is jaundice happening? The yellowish discoloration of the eyes is the bilirubin. So, there is something in the body which is causing the bilirubin levels to go up more than twice the normal limit of normal until the upper limit of normal until that you see jaundice. So why should anyone have hyperbilirubinemia? That is the question. And if we can answer that, we'll have a diagnosis at the end. So the to approach the causes of hyperbilirubinemia, I usually characterize them into either direct hyperbilirubinemia or indirect hyperbilirubinemia. So the starting with the indirect hyperbilirubinemia, this is something the bilirubin is up and it has not gone through the liver before. So causes include, for example, like RBC destruction, for example. So that
Hello,
is
Joseph. Hello, Joseph. Just a minute. I think you are loud, but then it's like you are a little distant from your device. Can you try and move closer?
oh, okay. Or am I?
Yes, there is like an echo in your voice.
I'm in an echo, eh? There is an echo.
Yes, now I think it's better now.
Yeah, I'm in a room where there is a lots of echo, and I can try to shift. So I was saying, bilirubin hyperbilirubinemia is what we translate as jaundice, and I characterize them as one. Can you hear me well, David?
Yes, it's clear now.
Yeah, there's in the room is lots of echo. So is a direct or indirect. I started with an indirect. I said hemolysis is one, which can cause indirect hyperbilirubinemia. But what are the other causes? So this includes when the liver, for example, cannot uptake the bilirubin and change it into direct hyperbilirubinemia. We talk about drugs like rifampicin can cause indirect hyperbilirubinemia. We're talking about heart failure with congestive hepatopathy, for example. The liver is so congested it can't take the bilirubin, so you have indirect hyperbilirubinemia. And you have benign and pathologic genetic diseases which can interfere with conjugation of bilirubin. We're talking about things like Crigler-Najjar disease, Crigler-Najjar syndrome, or Gilbert's, which can happen. But in most cases that I've seen of indirect hyperbilirubinemia in hospital, for example, turn out to be hemolysis. So in every patient with indirect hyperbilirubinemia, I look at hemolysis first. On the other hand, we have the direct hyperbilirubinemia. So the direct hyperbilirubinemia, it means there is a blockage somewhere which the bilirubin has been conjugated, but there is a blockage. It doesn't flow as usual and it's high. So what are these? These can be located at a certain place in that tree. So one, most important, is the CBD, the common bile duct. So if you have an obstruction of the common bile duct, you will have direct hyperbilirubinemia. And this can be blocked from inside or from outside. From inside, you're talking about things like a stone, so choledocholithiasis. You are talking about a sludge. You can't have a stone, but you have a sludge. And you also talk about rare things like parasites. So usually red and MD2 of fasciola hepatica can sit there and cause stuff, but it can come from the wall. So the wall can be inflamed or can be cancerous, and then it blocks. But again, it can come from outside. For example, carcinoma head of pancreas. It's an outside thing which blocks the CBD. Or someone can have lots of lymph nodes, like they have a lymphoma and they have a lymph node somewhere and it is blocking the CBD from outside. But again, you can have other causes elsewhere, like the CBD is extrahepatic, but you can have things from intrahepatic. So infections, hepatitis that you know, autoimmunity, things like we have these HBC, I don't know, but PBC and PSC. Yes, they tried to escape my mind. PBC and PSC. These autoimmune diseases can cause direct hyperbilirubinemia. And then, so you're talking about infection, autoimmunity, and cancers. You can have cancers of the biliary tree inside the liver, and then you can have direct hyperbilirubinemia. So I think when we go on, we will see there are ways that we can hear in the history and try to characterize what are we talking about. Is it direct or indirect? Thank you.
Yeah, thank you, Dr. Joseph, for an excellent introduction. So our patient had a second complaint, which was also abdominal distension for 1 month.
Yeah. So we have discussed, I think, twice here about abdominal distension. So it boils down to what is causing the distension. Is it fluid? Is it fat? Is it flatus? Um, or is it a solid tumor? So if you plus this, like there is jaundice and then there is abdominal distension, yes, you can have a number of things. For example, you can have maybe a cirrhosis, and then you have ascites as part of that cirrhosis, and the cirrhosis will cause also jaundice. So I think we should have more history.
Thank you again. So moving on to the yellowish discoloration of the eyes, which was there for 2 months. So it was of gradual onset. So it was not by her husband at first. So it's a persistent jaundice, which is increasing in intensity. So started from the eyes, and 1 month later, it involves the palms and soles. So it was associated with fatigue and passage of dark colored urine, but it was not associated with itching or passage of clay colored stool. There was no reported history of gum bleeding or easy bleeding tendencies, no fever, no history of weight loss reported. So the abdominal distension, which was there for 1 month, the onset was gradual. So initially it was more on the flanks, but as later on it progressed, becoming a generalized abdominal distension. So it was associated with a loss of appetite, a sense of abdominal fullness, together with early satiety. But there was no history of difficult or painful swallowing that was reported. No nausea, vomiting, heartburn, abdominal pain that was reported. There is no any history of constitutional symptom or open TB contact that was reported by the patient. No history of passage of blood or black tarry stool. There was no history of change of bowel habits, including constipation or diarrhea. So our patient does not have any history of anterior neck swelling, cold or heat intolerance. Patient did not have any positive history of hair loss, skin lesion, increased sensitivity to light, joint pain, or swelling. So our patient did not have any history of vaccination against hepatitis B, no previous history of using poorly stored grains. She's not a cigarette smoker, no history of intravenous drug use, but there is not any history of use of over-the-counter medication or herbal medication, no previous history of tattooing, alcohol drinking, blood transfusion, swimming in stagnant water, working in rice plantations, ingestion of raw or undercooked freshwater fish, a prior history of similar illness or caring for patients with similar presentations, multiple sexual partners. So a patient tested for HIV 1 month ago and it was negative. Yes, so that was HPI,
Yeah.
Dr. Joseph.
So can we go to the first slide of HPI? That's a very well taken history. Yeah. So this jaundice is starting to bring now a flavor that I can bet it's probably highly probable that's is a direct hyperbilirubinemia. Why? Because as I say, let's say if you think it's indirect, and the most common cause to should be hemolysis, but turns out if you hemolyze your blood, you it's not something that will be that just gradual unless the disease is such congenital, but you are normal, a 46-year-old, and then all of a sudden you hemolyze, you'll be unstable. There will be other symptoms, but this was a gradual onset. And as usual, jaundice first noticed by other people, which is okay. And it turns out is very high levels of bilirubin. That's you can see them even in palms and soles in a black person. And again, there is a passage of that colored that colored urine. So yeah, uh, if the bilirubin makes it into the urine, turns out it is soluble, and if it is soluble, it is direct hyperbilirubinemia, and there is no itching, which means maybe it is not the cause associated with the CBD blockage anywhere. And again, saying that there is no easy bleeding or easy bruising, of course, rules out some other things that can be associated. And absence of fever and weight loss. So in clinical reasoning, if something is there, you take it serious. But if it is not there, it doesn't rule out anything. For example, now there is no fever or weight loss. You can try to interpret it. Maybe you think patient is not inflamed, but that is not true. We will see later if maybe they are not inflamed. But so that because they are not there, they make us a bit breathe and wait for some other stuff. Next slide that I can see. Yeah, I think about this is the abdominal distension, and that is starting on the flanks, both flanks. Probably it's ascites, and then it made the way to be generalized, meaning that it increased in the severity of that ascites. Loss of appetite is very non-specific. Plus early satiety, abdominal fullness. That's how what it does, because the ascites is filling the abdomen. Next. Yeah, so I think this slide tried to rule out some other things. Okay, okay, yeah, especially the passage of black tarry stool, which means very important if you have jaundice and then you have ascites. One thinks of the common things, including maybe cirrhosis, and if you have that, you can have other complications, which include the upper GI bleeding, and then if you have that, you can have these black tarries too. But you can have the varices, and they have never ruptured, so you have never experienced the upper GI bleeding. That's why if you diagnose these people, at the end of the day, you have to scope them to see. And yeah, next. Okay, next. Yeah, this trying to rule out some risk factors. Very important, by the way. Hepatitis B or C in IVDU, um, Heb associated liver injury, and again alcohol drinking, blood transfusion. Of importance is the assuming the working in rice plantations, which tries to rule out probably periportal fibrosis, but periportal fibrosis should never present with jaundice, because it is not about the liver, it's about the portal vein. So I think that's not associated here. It can cause the ascites, yes, but it cannot cause the jaundice. I think yeah, the issue is we have hyperbilirubinemia, and probably we have ascites. And my thinking, this will turn out to be probably direct hyperbilirubinemia, and it is highly likely that it is also related with the ascites that we are seeing. And so to think of what is the cause of this, and maybe we should hear more history, say, about physical exam.
Thank you, Dr. Joseph. So in the review of other system, starting with the genitourinary system, there's not any history of reduced urine output or passage of frothy urine or blood in urine. In the cardiovascular system, no history of chest pain or difficulty in breathing. In the central nervous system, no history of headache, confusion, or convulsions. No history of blurred vision. There was not any history of altered sleep pattern.
Is that all? Okay.
Yes.
Yeah. So yeah, that's it. That's also very nice because there are lots of things that can be. If you have ascites and jaundice, you have lots of things, and then reviewing about reducing output, whatever that you have can also affect the kidneys. That is very understandable. And so CNS, if it turns out we have direct hyperbilinemia, we're talking about the liver. And if you're talking about the liver, it also does other things. And if its function is impaired, then you can have other complications of CNS, including the hepatic encephalopathy. So I think it was the history I was trying to rule that out. And yeah, it's very good that is not there. Next.
So in the past medical history, our patient has been hypertensive for more than 5 years. She's on regular medication of losartan and amlodipine, and the blood pressure is well controlled. In the family and social history, it was unremarkable.
Yeah, I've no comment for that. I think we should go on with the exam.
So coming to the physical examination, starting with the general examination, our patient was fully conscious, febrile, not pale, but she was deeply jaundiced in the sclera and palms and soles. There was no oral thrush, aphthous ulcers, no angular stomatitis, no any palpable inguinal lymph nodes. So all the other stigmata of chronic liver disease were absent in our patient. Vitals, all the vitals were within the normal limits. So coming to the abdominal examination, our patient had a generalized abdominal distension, which was moving with respiration. No distended veins were elicited, so the abdomen was soft, non-tender, no obvious palpable mass. So our patient had a shrunken liver, so the liver span was about 10 centimeter, and the spleen was not palpable. There was a positive shifting dullness, but the fluid free was negative. Our patient had normal bowel sounds and no vascular buoy. In the digital rectal examination, it had normal findings. So other systemic examination were fairly normal.
Yeah. Okay. So let's go to the general exam. The most important thing in general exam here, as Seba is presenting, is the jaundice. But we have heard that this patient of jaundice since the discussion started, and I've elaborated my approach to it. And so here it just proves that it is there. So no stigmata of chronic liver disease. These stigmata of chronic liver disease, they come from two things: pressure, like lots of pressure in the vessels, and two is the hormones. So there is a very nice series by this very famous doctor who teaches Stanford. He has a YouTube channel. I think is yeah, forgot his name, but he has a series called Physical Exam. He says a very nice thing in the introduction. He says physical exam are meant for, like, if you have something, you take it seriously. But if you don't have that thing, it doesn't mean you have ruled out that particular thing you are looking at. For example, you are looking for features of cirrhosis in this patient, like you have to see the spider angiomata and gynecomastia. But then, if they are there, you say highly likely we are dealing with cirrhosis here. But if they are not there, it doesn't mean this patient can't have a cirrhosis. So that's important. Even if these are not there, like the one we are used to here, the spider angiomata and the other stuff, still it will never dissuade me away from that. And in the next slide, I think the only finding is that the shrunken liver of 10, I believe, Saber, right?
Yes.
Yeah. So shrunken liver, ascites, hyperbilirubinemia. I can't think of nothing something else apart from a sclerosed, meaning a cirrhotic liver. So I another thing is the spleen is non-palpable. It is argued that for the spleen to be palpable, it has to be like twice the upper limit of the spleen, like enlarged twice. So even if it is not palpable, we have to do an ultrasound and find out. But why is the spleen enlarged in patient with liver diseases? Because of portal hypertension. And there's the portal hypertension also, which cause the ascites in these patients. So I would expect it to be enlarged at one point, and maybe we can see that in the ultrasound when Seba will tell about us about the ultrasound. But if I go back, we started sensing that this will turn out to be a direct hyperbilirubinemia, and this is where we are. Like it's coming from the liver. We haven't heard anything else outside of the liver. Like other systems are completely normal. Patient doesn't complain of any other system, but only of the things that coming from the liver. So we have direct hyperbilirubinemia, and we have ascites, as it is proven here, that is a shifting dullness with the shrunken liver. Ascites, I can translate it as portal hypertension, I said. Shrunken liver, this is fibrosed, sclerosed liver, a cirrhotic liver. As we are going on, I think the problem will be finding out why is this 46-year-old woman having cirrhosis, and there are no risk factors, but yes, risk factors are just risk factors. We'll be we'll be screening and finding out. We have ruled out some other things, like she doesn't use alcohol, very important. But in this area, hepatitis B then alcohol. So if she doesn't use alcohol, Seba will tell us in the labs how about the hepatitis B, and then from there we can discuss of other causes of cirrhosis. Yeah, it's to you, Seba. The slides are gone. What is happening?
I see Dr. David has left. Possibly he has encountered some technical problems.
So can we?
So Let me try to share mine, and also I'm reaching out to him.
Yours, I won't see them, but it's okay. I think you can continue. There is no problem. But you can
Okay,
put them up so other people can see them.
okay.
Oh, David is joined. David, hello, David.
Hello.
David.
Hello, Joseph.
Yeah, you. What happened to you? Can you put up the slides?
Yes, I completely disappeared. Like, just a second. My internet is very weak today. Okay, so can you see that now?
No, I don't know about
Hello,
others.
Joseph.
Hello, hello. Yes, I can see them. I can see them.
Yes, you can see my slides.
Yes, I can see your slides. So I believe we are at the.
Okay, so I think this is where we are, right? We're
Uh-huh.
now going to
Yes, yes.
investigations, right?
No.
Okay.
So I hope, Dr. Joseph, you can see the slides.
Yes, I can see the slides.
So we investigated our patient. Starting, we did liver enzymes together with other synthetic functions of the liver. So our patient had a significant elevated the transaminases, which is ALT and AST. The GGT and ALP were just a smidge above the upper normal limit, but significantly elevated total and direct bilirubin, and also an hypoalbuminemia of 29.
No. Okay. Thank you very much. So these labs are helpful. ALT is liver specific than AST, but they're both raised. And at least the ratio of AST ALT is not 2 that is used in alcoholic hepatitis. So they're like equally raised. Uh, the ALP being raised slightly elevated, but again it is coming from the liver because the GGT is also elevated. The important thing here is the bilirubin, and as we are seeing, this the direct hyperbilirubinemia is more than 50% of the total bilirubin. So this is the direct hyperbilirubinemia that we were thinking from when this case started. And then the albumin being low, it can be because of it, the synthetic the synthetic function of the liver have gone down. But again, a low albumin is a negative marker of inflammation. So probably this patient is also inflamed from other things that also we are seeing that they have a hypoalbuminemia. Yeah. So the liver is affected. It has caused direct hyperbilinemia, and probably there is an inflammation that is going on with this patient. Next, David.
Yes, I've moved my slides unless
Yeah, okay, I can see them.
it has taken
Yes.
some
Yeah,
time, but I've moved the can you see the next slide?
yeah, I can
So
see.
coagulation profile was done, and also the acetic fluid analysis was done.
Now, I can see them. Let me go direct into it because of the internet issue that you're having. So yeah, the PTT, they're also part of the liver function. But
Hello, Joseph.
hello, can you hear me? Can you guys hear me? Seba, can you hear me?
Yes, I can hear you, Dr. Joseph.
I think there's a problem with David's internet today. Because
Okay.
okay, yeah. So we are seeing here the PT is elevated, the PTT is elevated, the INR is elevated. So the PT, we can interpret it in the line of INR is the same thing. This is just normalized with the value that the lab is using. And so the PT represents the, I believe the PT represent the extrinsic factors, and the extrinsic factors, these are, I believe, is factor 3 and 7, I think. And then the PTT represent the intrinsic factors, which are factors like, if I think so, factor 8, 9, 11, and 12. So both are elevated. So it means all the factors, maybe they are impaired here, which include the common pathway, for example, the extrinsic and the intrinsic. Someone can be interpreting this like that, but
Yes, we can hear you, Joseph.
I think the others can hear me. But David, there's a problem with your thing. Yeah. So let me continue. So I was talking about the factors and what they represent and what are they. But remember, when it comes to the liver and you're talking about the coagulation profile, you should think of what is called vitamin K dependent factors that are involved with the liver. And these are factor, I think, 2, 7, 2, 7, 9, and 10. Yes, so if you look at them, they cut across their intrinsic, extrinsic, and common pathways. So that's why everything is impaired. So this just translate that the liver of this patient is sick. And I saw another thing beside there. What was this, Seba? The other slide, the other labs.
So the other labs was acetic fluid analysis.
Yeah, can you read that for me because I didn't put them in.
So protein was 21 grams per liter. Yes, cytology had scant lymphocytes, and also acetic adder was 2.2.
Yeah, so they didn't do the albumin. Okay. So this is the total protein of the of the ascites? Does it mean is the albumin or something else? Seba.
I think this is the for the albumin.
Okay. Yeah. Okay. So this is very nice. Whatever this patient was taking care of, someone to take this and do this stuff is very good. So for me, I would if you're giving me ascitic fluid albumin, I think you gave me the serum albumin previously. I'll calculate the SAG, right? The serum ascites albumin gradient. And what was the albumin? You said it was how much?
So it was 29.
It was
29.
it was 29. It was 29, right? So if you take that you take that difference, you take like it's like 8, eh? It's like 8, yeah. And 8 is above the level, the 1.1, which means we are dealing with a portal hypertension. Um which we also thought it has to turn out like this if you are talking about a shrunken liver translating into cirrhosis, ascites because of portal hypertension. We expect a SAG to be above 1.1, and that's it. Um, the other things, cytology scant lymphocytes, because when you do cytology, we want to see if there are elements of malignancy in that ascitic fluid. But scant lymphocytes, I cannot tell much. So other it doesn't do anything for me unless I'll be struggling with the diagnosis at the end. I'll turn back to this other. But of now, I cannot say anything about it. So next, David, next slide.
So serology panel was done for this. Also hepatitis A, hemoglobin M was negative. HIV serology was also negative for this
Hello,
patient.
Joseph. I have moved, but I think my internet
Yeah,
is slow.
yeah, there is a
So maybe Seba can just
yeah, sure. I can see them now. Yeah, so we think we're dealing with cirrhosis here in a late 40-year-old female, and the thing now is to find out what is the cause. I think this journey has just started, and Seba is telling us that there is no hepatitis B, there is no hepatitis C. This patient doesn't drink alcohol. So, what is it? I think I should go back and now start to reflect how I think about the causes that can cause cirrhosis. So you can divide them into categories. Mine is first. I consider of is the cause coming from the liver parenchyma itself, or is the cause coming from outside? I mean the biliary system. Those two. I know there is the one that we were taught in medical school, very good by the way. It's also written in Harrison. Uh, the pre-hepatic, intrahepatic, and post-hepatic. But I think if I think like two groups, inside the liver, outside the liver, it makes it so easy. So if talk about inside the liver now, what are the things here? So we all know about the infections which have been ruled out in this slide: hepatitis B, hepatitis C, and another one is meds and toxins. We're talking about alcohol. This patient doesn't drink, so it doesn't make sense. Another one, especially more in the West, is the fatty liver, the uh, non-alcoholic steatohepatitis. We were not told whether uh, we didn't hear in the history whether this patient was obese at all. And again, there are autoimmune diseases of the liver, like autoimmune hepatitis. So autoimmune hepatitis, if it is recurrent or not treated, it can turn out and cause fibrosis of the liver. Um, what else? I think there is another group that I'm forgetting. Yes, so the infiltrative disease, very important. We're talking about Wilson's disease here. We're talking about hemochromatosis. Seba didn't show me the full picture of this patient. I think you show me later because it was important. Hemochromatosis is important. Wilson's disease, and there are others that, but I think I cannot remember them for now. So yeah, those are the groups that I can think of inside of the liver that can cause a cirrhosis. Infections, medicine toxins, obesity, infiltrative disease, and autoimmunity. So if we go outside of the liver and we talk about the biliary system, for me, when I say outside of the liver, it's just to orient myself. But the biliary system, also cuts inside the liver. But I used to put them as outside and inside so that I can make it easy to remember. So I mentioned two things initially: the PBC and PSC. I believe the one which is common in females is the PBC. Yes, it's the PBC more than the PSC. So also these are important. But patient will be like uh, there will be other histories like scratching and stuff, and they're usually younger females. But again, the diagnosis will be made maybe on a liver biopsy, but you never know what it turns out to be. Do I have anything else? Okay, if it will come later, I will discuss later. But for now, yeah, let's continue, Seba.
Thank you, Dr. Joseph. That was excellent. So for the part of BMI, the BMI of our patient was within normal limits. It was 23.1. So the CBC complete blood count was done, which had normal parameters. The renal function tests were also within normal range. Electrolytes were normal. The thyroid function tests were within normal limits. For the inflammatory markers, our patient had a bit of elevated C-reactive protein, which was 16.4. Also, ESR was elevated around 40, and also alpha fetoprotein was done, but it was only 5.3. Also, OGD was done for this patient, and it had normal findings.
Okay. So one thing here that throws me off is the football picture with the normal platelet. This is so unusual. If this patient will turn out to be a cirrhosis and then they have a normal platelet, it's so unusual. But yes, maybe things happen. But I expect patient with cirrhosis to have a reduced platelet level because of what happens because of portal hypertension. They have hypersplenism, they have sequestration there. Um, the CRP and ESR, this patient is inflamed. If they are inflamed, they can have an infection, they can have a malignancy, they can have an autoimmune disease. We are waiting to hear what is happening. AFP 5.3 is normal, Seba, right?
Yes, it is normal.
Yeah, it is normal. So I think we do that because we want to see this HCC, but even if it is normal, it doesn't say it is not there, right? We have to do other things. We do an ultrasound and we see if there is any signs that there is any nodule, and if there is any nodule, we order some kind of CT, and then we look at the liver. So OGD being normal, it means if we turn out to be a cirrhosis, and then there is no varices. Yeah, so I'm in between. A lot of things are saying this is cirrhosis, but Most important is the shrunken liver, and there was no stigmata, and the platelet is also normal. These are against that saying that it's a cirrhosis. But yeah, patients can present the way they want. We'll see at the end. Let's continue. It's,
So, would you want to commit yourself, Dr. Joseph, or there is an additional investigation that you need to further assist you in the diagnostic formulation?
yeah, I wonder why there was an ultrasound. I don't know if that will, is the one which will tell me.
So, CT scan was done for this patient,
No ultrasound.
and it revealed a yeah, no ultrasound. I think it was, but for the I think ultrasound was done, but we had the CT scan
So you
reports.
mean the CT scan will reveal the diagnosis, or should I say what I think before?
You can commit yourself.
Yeah, yeah. So for basically, I will have an ultrasound, but yeah. So since this journey, um, to think the major problem here that we were going back and forth was jaundice, and most commonly, patients with jaundice in hospital will have a direct hyperbilirubinemia. This patient turned out to be, and if they have a direct hyperbilirubinemia, say there is an obstruction somewhere. That's why we do an ultrasound. I doubt if a CBD is obstructed here. So the obstruction is happening within the liver itself. And the most important thing that was picked by whoever did the physical exam, very meticulous, they found a 10 centimeter liver, shrunken liver. That that should say this is if it's shrunken liver, this is a cirrhosis. But there are other things that are going against cirrhosis. For example, there are no stigmatas. Most patients that I have seen in with cirrhosis, they have stigmatas. They have stigmatas. But this is no stigmatas. So that one throws me off. And then the platelet is also normal. Also, that's the second thing that throws me off. So you find yourself saying, okay, if this is not cirrhosis, then what is it? Is there any other thing that can cause a shrunken liver and ascites and impaired liver functions, inflamed liver, ASALT, everything is up. Yes, you can have some stuff. For example, you can have these thrombus which sits in the blood vessel, but this will cause this will cause abdominal pain. So yes, I still think it's a cirrhosis. Very unusual that those things are not there. The other thing is the cause. What is the cause? So hepatitis, very common here. Hepatitis B, it is not there. That patient doesn't drink. No hepatitis C. What else? I've talked about it. Being a female in the 40s, I'll put up there autoimmune hepatitis or um, PBC. But again, PBC is less likely. There will be other symptoms. This patient, they have pruritus like hell. They have lots of pruritus. So maybe autoimmune hepatitis. Maybe autoimmune hepatitis. Yeah, so yes, I think it is still cirrhosis, SEBA, and the cause for me be autoimmune hepatitis. Who to diagnose it, you need a biopsy.
Thank you, Dr. Joseph. I think that was excellent. You actually pinpointed exactly to our diagnosis, which was decompensated liver cirrhosis secondary to autoimmune hepatitis. So autoimmune profile was done to our patient. So our patient had a significant elevated anti-nuclear antibody with ratio being 1:105, together with a positive smooth muscle and antibody, and significant elevated serum immunoglobulin G, which was more than 1.5 times the upper limit. So just some few learning points regarding today's diagnosis. So autoimmune hepatitis is the rare chronic immune-mediated inflammatory disease of the liver that is characterized by you have circulating autoantibody, increased concentration of the immunoglobulin G, and also distinctive histological features. So as Dr. Joseph, you have said that almost always to make a definite diagnosis of autoimmune hepatitis, you'll need a liver histology, but you can have a probable diagnosis of autoimmune hepatitis without having a liver storage. So autoimmune hepatitis predominantly affects male, same as for most of the autoimmune disease, usually have a female predisposition. So the ratio is about 4 to 10, ratio 1. So it has two uh, peaks. So the first peak is around the second decade of life, and the second peak is about the fifth decade of life. So it has a variable spectrum of presentation. This is the disease that may be totally asymptomatic, such that patients may only be diagnosed as an incidental finding when they are going through other diagnostic procedures. But also this is the disease which can present as an acute fulminant hepatic failure, but it can also present as a chronic liver disease, and usually it has a fluctuating pattern. So as autoimmune conditions, usually they have a tendency of occurring in clusters. So there are some of the extrahepatic autoimmune that may be associated with uh, autoimmune hepatitis. So the one which is mostly implicated is the Crohn's disease, but it can also have diseases such as the autoimmune thyroiditis, the Hashimoto, also connective tissue disorders such as rheumatoid arthritis and systemic lupus, and also diabetes type 1.
Sure.
So autoimmune hepatitis can be classified into two major groups, which is type 1 and type 2. And the criteria for classification is usually based on the autoantibodies profile. So usual type 1 consists of the autoimmune markers, which is ANA, ASMA, and AMA. So our patient had a positive ANA and also ASMA. So most probably our patient falls into the category of type 1 autoimmune hepatitis. So type 2 autoimmune hepatitis consists of autoantibodies, which is LKM1 together with ALC1. So in the laboratory picture, in the liver enzymes, so usually this is the disease which presents with significant transaminitis, such that there will be significant elevated above fivefold with respect to the GGT or ALP, which usually they're elevated in very small amounts above the upper limit. As you can see in our patient had significant elevated the ALT and AST, but for the part of GGT and ALP, they were just smidge above the upper limit. So in more than 85% of the cases, these patients usually have elevated immunoglobulin G. Our patient had elevated immunoglobulin G, which is more than 1.5 times the upper limit. And also, as I said previously, had positive ANA together with smooth muscle antibody, which is very specific for autoimmune hepatitis type 1. So there is a simplified diagnostic criteria for autoimmune hepatitis. So this is having a number of scores here. So having a positive ANA or smooth muscle antibody, uh, which is having 1:8 will give you 2 points. Our patient had 1:105, so our patient will score 2 points here. So presence of immunoglobulin G that is more than 1.1 times the upper limit, will give you 2 points. So our patient had 1.5 times the upper limit. So our patient had another 2 points here. Also, liver histology was not done for a patient, but there is an absence of viral hepatitis, which will give us 2 points. So we can see from this our patient had 6 points. So presence of 6 points will give you a probable diagnosis of autoimmune ischemic hepatitis, and presence of 7 or more points will give you a definite autoimmune hepatitis diagnosis, even sometimes without liver histology. So liver biopsy is considered the hallmark for making the diagnosis of autoimmune hepatitis. There are some of the typical findings of autoimmune hepatitis, which is interface hepatitis, hepatocellular rosette formation, together with peripolesis, which is an active penetration by one cell into a large cell, and usually they're associated with hepatocyte swelling, together with necrosis. So in the diagnosis of autoimmune hepatitis, you can have a mild disease, an active disease, or you can have advanced fibrosis together with cirrhosis. So our patient had already shrunken liver, together with all the findings which were highly suggestive of liver cirrhosis. So our patient fell into the category of advanced cirrhosis. These are the patients you're supposed to treat if you have an active disease or advanced cirrhosis. So treatment for our patients, advanced cirrhosis, then they have to undergo induction therapy, and induction therapy, usually glucocorticoid therapy, is the cornerstone. So induction therapy was done by using prednisolone, in which the dose is usually 0.5 to 1 milligram per kg per day for 2 weeks. Then you monitor the level of the transaminase. The target is at least to achieve at least more than 50% reduction of the transaminase within a time frame of 2 weeks. Also, one other prognostic marker is also the serum IgG and also the total bilirubin. So usually before initiating azathioprine, which has elements of possible azathioprine is capable of inducing also drug-induced liver injury. So you have to make sure that induction of prednisolone has been done and you have achieved as reduction of the transaminase by more than 50% reduction from the baseline. That is when you can initiate a patient on maintenance on azathioprine, which is considered the major therapy in maintenance. But if azathioprine is contraindicated, specifically in patients who are having a significant bone marrow suppression, then there is a role of other therapy by using other immune modulating drugs such as the mycophenolate mofetil or cyclophosphamide. So usual treatment is supposed to be continued for 3 or more years and for 24 months after completing normalization of the serum transaminase together with normalization of the serum IgG levels. So in terms of prognosis, the general prognosis, this is the disease that is associated with 50% mortality in 5 years. And there are some of the factors which are negative prognostic factors, which are cirrhosis at onset. So a patient is having a cirrhosis at onset, which is the negative prognostic factor for her. Also young age at onset, also having repeated relapse of active disease. Also being black is a risk factor for, it's a marker for poor prognosis. Also vitamin D deficiency. Yes.
Yeah. First of all, thank you very much. Very well worked upon patient. So unfortunate that she has already cirrhosis setting in. But yeah, we got an opportunity from her to learn. We jogged and reminded myself and everyone here about the approach of so many things. And yeah, I'll emphasize one thing that, as you saying, liver biopsy is necessary because, you know, like if you take, for example, the cutoff of 1:8 ANA, 20% of people in the population, if you take their blood, they'll be positive. And if that number is only females, it will also go up again. So, and again, if you have maybe you have drug-induced hepatitis, drug-induced hepatitis will later slowly and slowly asymptomatic going on and cause cirrhosis at the end. It's very possible. There is, take paracetamol for example. If I ingest 10 tabs, I'll have an acute hepatitis from paracetamol. But if everyone takes paracetamol at one point, there are people very susceptible. They will take some dose of paracetamol in several years, and they have a silent asymptomatic hepatitis slowly and slowly, which will turn out later to be a cirrhosis. And you cannot tell the difference between that and the autoimmune thing unless you do a biopsy. So that's important. But yeah, ASMA being positive, ANA being positive, being a female, I think that's, yeah, you're on the right track. Thank you very much.
Okay. Thank you, Joseph, and thank you, Seba, for presenting the case. Now I think we should just take a few minutes and welcome the floor if there are any comments, any questions before we close, because I think we are already beyond the mark. So if anyone has any comment, any question, you're welcome. Just I see the floor is silent. Thank you very much, Joseph. I think again this was an incredible case. I believe at least in our training, for most of us, we've come across cases of decompensated liver cirrhosis, but then I think this underscores another important fact in clinical reasoning, that sometimes you get a diagnosis or a syndrome, and then that's just the beginning of a journey. For example, in this patient, yes, it's I think at least up to physical examination and maybe right from the history, you already had some clues that we are dealing with cirrhosis, but then what is the cause of the cirrhosis? So that started another journey. So yeah, I think it was an important learning exercise today. I believe most of us have learned from Joseph's approach. So I think it has added something to our knowledge bank. So maybe before we close, if Seba or Joseph, you have anything, you are very welcome.
I just want to thank Seba and the team who took care of the patient.
Thank you, Joseph. Seba, anything from your side before we close?
Thank you, Dr. Joseph. Thank you, Dr. David. And thank you for all the members of the floor who attended. I think this is very helpful.
Thank you very much, Seba, for your time putting together the slides and presenting. So one more time, we encourage people who have cases to reach out to us so we can get to learn from the incredible cases that you see on your daily practice. But again, people who are interested in discussing, again, very much welcome, because we need to learn from each other. As you can see, this is not meant to be a teaching session, but rather to learn from the thought process of any colleague who will be generous enough to share with us their thought process. So if anyone is interested in discussing a case, either as a solo discussant or if you want to discuss with someone, you're very much welcome. So having said that, I thank everyone for joining us today. I wish you a good night and we'll see you next weekend.
Good night.